I would like to welcome you to Texas Physicians for Social Responsibilities. First, CME, or Continuing Education. My name is Rebecca Bernhardt. I'm the director of Texas PSR, and we really hope to have more climate and health related continuing education options in the future. So this event is co-sponsored by the Alliance of Nurses for Healthy Environments and UT Health Sciences Houston School of Public Health, Southwest Center for Environmental and Occupational Health. And there will not be a quiz on how to say that at the end. I'm going to just mention again that if you've logged on recently, we'd like you to keep your cameras off so that we don't crash the system. I would also like to introduce Dr. Ronda McCarthy. Dr. McCarthy is the National Medical Director for Concentra's Medical Surveillance Services. She's worked as a clinician for 30 years with expertise in treating heat illness and operating heat illness prevention programs. She has testified before Congress on heat illness prevention. Take it away, Dr. McCarthy.
Thank you. Thank you, Becky. And please let me know if you are having trouble hearing me. So when Becky asked me to speak on heat-related illness this past year, we had no idea that we'd be in the midst of a heat event this summer. And with the 2 recorded hottest days on record globally this past July 3rd and 4th, with the expectation that more is coming, and thank you, that the audio is good, I appreciate it. So I usually like to start out with a story to make the topic more relevant to the audience, but you, I, and our patients are living the story. And we all must be aware that heat exposure and how we as clinicians can help our patients, manage stress. Next slide, please, Sylvia. So I do work for Concentra, and Concentra provides heat stress medical surveillance. So ongoing surveillance or medical monitoring to evaluate for Concentra, a national occupational health care provider, those who work with heat exposure for early health effects from that hazard. We also provide injury care for those with heat-related illness and return to work evaluations. Next slide, please. So this evening, I hope that our learning objectives will be today to identify those populations that are at increased risk for heat-related illness, to understand the fundamental methods to prevent heat-related illness, or HRI, learn how to medically monitor your heat-exposed patients, and further prevention through patient education. And of note, this is really a bird's eye view of heat illness and preventive measures. We cannot go into all the technical details, but there are references, resources, and our emails, Becky and my emails at the end, should you want additional information. But please put your questions in the chat for a Q&A at the end. Thank you. Next slide. So it is hot. Texas is hot. We as clinicians, especially us that have lived in Texas our whole life, I think of it as like a fish in their environment. What is water? Why are we learning about heat illness? But it's getting hotter, and heat introduces a wide range of serious health hazards. But fortunately, heat-related illnesses are preventable, and we as clinicians can be a trusted first line of defense for our patients. Next slide. Again, it is hot. The hottest years on record, according to NOAA, National Oceanic and Atmospheric Administration, have been approximately the past decade, 2014 to 2022. And like I said earlier, we have recently had the hottest days on record. Next slide. And it's getting hotter over the years. Here locally in Texas, we have had longer hot season. There are more summertime days with temperatures over average. And here this shows Houston with additional 53 days compared to in 2022 compared to the 1970s. So we're having more years, longer seasons, and hotter days. And the trend is expected to continue. Next slide. And every year, thousands of individuals experience heat-related illness and hundreds result in fatalities. The direct impact of excessive heat exposure can range from something very minor, such as heat rash, to heat stroke, which can be fatal. Heat-related illnesses such as heat exhaustion must be taken seriously because it can progress quickly to heat stroke if the heat exposure continues. In addition, there are, to the 5 diagnoses here that we typically think of with heat illnesses, there are also other injuries that are associated with heat, such as traumatic injuries. When we have cognitive impairment or irritability, we are more likely to get into an accident. Working around hot surfaces with that heat exposure, we can be more susceptible to burns. Also, there's renal pathology, acute kidney injury associated with dehydration and heat exposure that can lead with repetition can lead to chronic kidney disease, rhabdomyolysis with exertional heat exposure, and exacerbation of existing conditions. Next slide, please. But the best intervention for heat illness overall is prevention. Next slide. But to understand better how to prevent heat-related illness, we need to have at least a general understanding of how our bodies balance heat. So just on a bird's eye view, heat contributors to our bodies that must thermoregulate this addition to our own metabolic rate are the environment, that can also have contributors of clothing and personal protective equipment, such as athletic and then work-related personal protective equipment, such as hard hats or like a chemical protective suit or football gear for athletics. And then also our own metabolic activity, which is increased significantly with the higher the physical demands. And then individual factors that can increase our heat vulnerability. And this is offset by we use physiologic and behavioral mechanisms, such as vasodilation, evaporative sweating, and of course, seeking relief, behavioral mechanisms such as cooling, rest, and fluids. Next slide, please. So the role of clinicians in the management of heat stress is to be able to recognize patients, and especially those at increased risk, because those that are increased risk make up the majority of the heat-related illness and can have more severe illness. Monitor for the health effects of heat exposure in all of our patients, and especially those at risk, and provide education and risk-specific counseling for the prevention. Next slide. So let's look at recognizing risk first in our patient population and individuals. Next slide. In order to help our patients, we need to know who needs our help the most. And populations at increased risk should be targeted for monitoring and preventive measures. So you may be aware of these and hear about them recently in the news, but at-risk populations in general include the very young and the very old or elderly. 60 and above, 65 and above, you'll hear, and the very young, ages 4 or 6 and younger, and infants, obviously. Women who are pregnant, athletes, all categories, school age, weekend warriors, and professional. Outdoor workers and indoor workers without climate control, and those with housing insecurity. There are other groups, but these are the groups we'll focus on. Next slide, please. We will also look at risk factors that can affect any individual, but also compound these at-risk populations. So looking at these risk factors, these can make a person more vulnerable to the heat. Persons who are obese or have a BMI greater than 30 are 3 times more likely to have heat-related illness, research has shown. they are not able to dissipate the heat or retain the heat for longer than those less than 30. Persons who've had a prior heat-related illness may have long-term issues with thermoregulation. Persons who have skin conditions such as anhidrosis or for various reasons, or extensive scarring from burns can have impaired sweating, and that can increase their risk. Also, those with acute illness, such as a gastroenteritis, and these acute illnesses can come into your offices frequently. That can set them up for dehydration and a heat-related illness. For an example, one of a firefighter that I saw went to work after 2 days of a gastroenteritis, went only to fight a fire, to be sent to the emergency department for a heat-related illness. Certain medications and existing illnesses can also interfere with individuals' thermoregulation. Next slide, please. So existing illnesses can be triggered by heat exposure and exacerbate that existing illness. And these include cardiac disease, renal, pulmonary, mental illness, and diabetes. And this exacerbation can put them at increased risk for HRI. For example, you must have an intact cardiovascular system to balance the heat load, just like we previously discussed. One of the most important roles of the cardiovascular system in thermoregulation is to circulate that warm blood from your body to the core and to the skin for heat transfer into the environment. When the body's at rest, in the absence of heat strain, the skin blood flow is approximately 200 milliliters to 500 milliliters per minute. So not very much, but it can increase to 7 to 8 liters per minute when under high heat strain. So that requires an intact cardiovascular system. So under stress and exacerbate, you can see why heat-related illness is often diagnosed as cardiac failure. Next slide. Medications, certain medications, and this is the categories. You have listed the categories of medications that can affect thermoregulation and increase a person's risk for HRI. So there's drugs and dietary supplements that can affect thermoregulation by impairing sweating, cause cardiovascular disturbance, such as peripheral vasoconstriction, or impair the cardiovascular performance, increase heat production, or cause disturbances in water and electrolyte balance. Such as the stimulants can decrease a person's perception of fatigue, which might hinder the voluntary termination of their physical activity, putting them at risk. So in summary, on these risk factors, clinicians have the responsibility to recognize who needs monitoring and education on their risk factors or their personal risk factors, and maybe even considering what medications may put them at increased risk, and weigh the risk-benefit ratio. Say of an antihistamine that's in the summer that they take every day, all throughout the year, and is it important for them to have that in light of being an outdoor worker or an athlete at that time? So those are just some things to consider. Next slide, please. So next, let's look at strategies for reducing risk by screening and monitoring our patients. Next slide. So now you know what populations are at risk. How do you screen individual patients? So here are just a few ideas. One is simply by having increased awareness and a higher index suspicion for patients presenting with symptoms and relevant history. So just learning about heat illness, reading about it, attending a CME conference like this, just having that increased awareness of who needs to be recognized when you're seeing your patients in the office. But another option is to screen your patient population for risk factors, using a screening tool such as a questionnaire, and adding that screening and medical monitoring to those higher risk patients, and looking for early health effects of heat exposure. Next slide, please. Here's an example of a screening questionnaire that you could provide to your patients through a portal, an email, or mail, ideally in the early spring prior to the hot season. There's a QR code there if you want to capture this questionnaire. Basically, it only takes a couple of minutes to complete. It brings heat stress aware. One great thing about it, if you provide it to your patient, it brings heat stress to their awareness, and it advises the patients what risk factors, because it's asking them it's asking specifically what risk factors they may have that might increase their risk for heat illness. And if they check any positives, it asks them to schedule an appointment for further evaluation. Also it provides a link, it provides some information to get additional information on preventive measures before coming into the office. So the goal of the screening questionnaire is to identify those at-risk patients and sort them into no increased risk or into increased risk. We're all at risk for heat-related illness, but we want to focus on those who are more likely to have a heat illness and more severe effects, since we can't see the entire population. Next slide, please. The medical evaluation. So if you bring those identified people through the screening questionnaire, or you're just simply identifying them through persons coming in through your office, you want to look at the medical and occupational history to focus on those risk factors, as well as during a well visit exam. Also, physical exam, concentrate on age, blood pressure, BMI, pregnancy status. And as far as the physical, looking also at the cardiovascular, respiratory, nervous, renal, musculoskeletal, and skin. Testing. For those persons who you know are exposed to heat at an ongoing basis, such as an athlete or a worker that has heavy physical demands in a hot environment, testing that you may want to include are serum creatinine, GFR, creatinine kinase with acute illness. These can be markers that you can follow to see if they're having kidney effects on their early health effects on their kidneys. After you have this information and you identified those risk factors, provide counseling, the general preventive measures and their specific at-risk issues and what they can do related to their specific risk factors. Next slide. For return to activity, clinicians can make a significant impact. So you may have a patient that did have a heat-related illness, were seen in the emergency department. It may be diagnosed as dehydration or heat exhaustion. And these may be athletes or workers. Of note, there is no federal worker protection for heat exposure. And so there are no acclimatization process, and many athletes in schools do not have an acclimatization process as part of their athletics. So if you have an athlete, a school athlete, or a worker who you are returning back from a heat-related illness or other illness into the active environment that is during the summer months or during the hot season, you want to ensure that that patient is asymptomatic. If they had a heat illness, that their biomarkers have returned to normal. And this includes the serum creatinine, liver enzymes, and possibly creatinine kinase as well. If they didn't have those drawn, you may even want to draw them just to make sure that they are normal, depending on the severity of their illness. So even persons with heat exhaustion or acute kidney injury could have elevations in these biomarkers. And then talk to your patient about how did the heat injury, the HRI, happen in the first place, and have an action plan, create an action plan together to prevent this reoccurrence. And where your guidance can make an impact is reacclimatization. Of note, just if the patient is persistent with symptoms or persistently elevated biomarkers, they should receive further evaluation with a specialist such as nephrologist. So the acclimatization, again, there is no current OSHA standard related to heat. And so there's no required acclimatization or even requirements for rest breaks or others to protect workers. Next slide, please. OSHA states that 75% of outdoor fatalities related to heat occur in the first week of work or returning to work in a hot environment after an absence in unacclimatized worker. So this lack of acclimatization presents a major risk factor for all fatal outcomes. Clinicians can play, like I said, an important role in the preserving athletes and workers' health in this return to work or return to activity exam, and by providing an acclimatization schedule. And you can see it here in the stepwise ladder by just by increasing their heat tolerance gradually by 20% each day. So the minimum amount you can do as recommended by NIOSH and OSHA, is adding 20% or 2 hours on day 1, 40% on day 2, 60% or 6 hours on day 3, and so forth. But patients who have significant risk factors or returning from a significant illness may need an extended schedule over 7 to 14-day period. The clinicians who may be involved in a school athletic program or even have a relationship with an employer may even want to recommend a acclimatization schedule for all incoming athletes, say for football players at the beginning of their practice season, which typically starts in August, and make recommendations for an acclimatization schedule. Next slide. This slide just shows the physiology of acclimatization that occurs with gradual exposure to heat. And if you can follow the lines, you have earlier onset of sweating, greater production of sweating, lower electrolyte concentration in the sweat, decreased heart rate, and decreased core temperature with heat exposure. So overall, you have just basically more thermal comfort as well in the hot environment. Next slide, please. So, and last, let's put that prevention into practice with our identified patients, and we have them in the office, or we can provide even mail or other ways to talk to them about the prevention. So let's break this up into three topics. I'll break it up into 3 sections. Next slide, please. We'll look at the general preventive measures, specific strategies for at-risk patients, and a real-world example of how this was put in place. Next slide. General preventive measures are what you see every day now in the news, but it's important to talk to your patient about these measures. These measures have more impact coming from you. There are also many myths and mistaken ideas about heat stress that you can address with your patients. I've done the heat stress counseling over the years as I've seen patients in the office, and sometimes they have put themselves at risk because they thought being in the hot environment and going to a cool environment might put them in shock, or drinking too cold of water or putting cold water on their body may put them in shock. And so dispelling some this myth or others can help save lives, basically. So talking to them, and then also giving them permission not to push through signs and symptoms of heat stress. Some individuals may look at it as a sign of strength to be able to push through these symptoms. And some individuals look at withholding water as a way to acclimate to the heat. Withholding water obviously can impair the sweating. workers who spend 8 to 12-hour shift outdoors can need often like 6 to 7 liters of water to make up for the sweat that they lose, depending on with heavy activity in a hot environment. So, and then you also have the behavioral mechanisms that can be overridden by the drive to impress a coach or an employer, and that can be pretty strong. So I think the American Academy of Sports Medicine says that the number one cause for death in school-age athletes is at practice is heat-related illness. So these general measures that we see, checking the weather before you go outdoors, light, loose clothes, hat, using sunscreen because sunburn can impair your ability to thermoregulate and sweat, drink, rest water shade, cool often, don't push through. And then the buddy system is so important. Because once you start having neurologic symptoms, you don't know to take yourself out of the situation. Monitoring your urine. If people don't say they don't know how much to drink, you'll often see drinking 8 ounces every 20 minutes. And a lot of people don't really think that way. So, they say, don't get thirsty or drink before you're thirsty, but monitor your urine frequency and color. If you're not urinating pale yellow and it's more dark orange, or and of course, this is without vitamins, you need to be drinking more fluids and to seek medical aid early if your symptoms aren't improving. So help your patients understand that they will be more productive and with regular rest, water, and cooling, and to pay attention to their symptoms and give them permission to monitor their symptoms and take these rest breaks and cooling breaks. Next slide, please. So the signs and symptoms: headache, dizziness, fatigue, heavy sweating, nausea, irritability. You'll see others. These are the common. They're pretty vague. You can just be having a bad day and having these symptoms. But if you're outdoors, it's hot, and you have these symptoms, get cooling, get to a cool place, rest. If they don't abate in 15 to 30 minutes, or you're feeling worse, then seek medical attention. Obviously, if you have a co-athlete, worker, friend that you collapse or are confused, this requires rapid cooling and emergency medical response. Next slide. There's often confusion on when you should call 911 because heat exhaustion can go to heat stroke very quickly if left untreated, and it can happen very, very quickly. And heat stroke can become life-threatening in a short period of time. The American College of Sports Medicine says to treat heat stroke as you would cardiac arrest. That the treatment in the field is imperative to success of saving end organ damage and preventing a fatality. So when the person starts having confusion, becomes incoherent, doesn't act like themselves, obviously unconscious, seizure, that's when you call 911. But you do rapid cooling in the field. If you had a rectal thermometer, could do a core temperature, then you do want to take that so you have that documentation, but that's not necessarily, we don't have that ability when they're in the field. Next slide, please. So again, with heat stroke, the American College of Sports Medicine states to have rapid recognition, rapid assessment, and rapid cooling. So for those entities that are set up, like for professional athletes or even workers who are known to work in a hot environment, to have emergency response teams, to have that recognition, assessment, core temperature, and rapid cooling. The most effective forms of rapid cooling are immersion in ice or cold water to the neck. If you don't have that available, cold water dousing any way possible. Wet the person their entire, take off any extra clothes they may have and any personal protective equipment, wet their clothing, or use a tarp assisted immersion of cold or ice water, towels or sheets, anything, and use that evaporative cooling, do fanning until emergency response occurs. So, people may be hesitant to do that. There's little risk with cooling them, but you can save end organ damage and potentially a death. So the sooner that is started, the less likely for organ injury and death. Next slide. So the best intervention for heat illness overall is prevention. But if it should occur, pre-hospital rapid cooling saves lives. Next slide. So let's look at just a few scenarios for the at-risk populations and how you can provide some strategies of counseling to help them to partner with your patients so they can help themselves manage heat stress. So for children, have metabolic and behavioral considerations. They're less efficient thermoregulators. They have smaller cardiovascular output, higher metabolic rate, and they are often active outdoors, and their play can be structured to unstructured, and they're dependent on their caregivers for behavioral responses. So let's say you have two parents, say you're in an office and you see your medical support staff is walking back a young couple with an infant and a toddler who come in for a well child checks in July. And you notice as they're walking back that the infant is flushed, irritable, wrapped tightly in a heavy blanket, and the 3-year-old is walking back drinking a Coke. And you think to yourself, this is a good opportunity for heat illness or heat stress prevention counseling. When you get into the room, what are some of the things that you would think of to counsel for children specifically? Let's look at those. The big one that you see over and over again, always take this opportunity, is never leave infants or kids in a parked car. Not for any amount of time, not even if the windows are open. Just don't ever leave kids in a parked car. I know now I see that they say, in the car seats, put a stuffed animal in the seat. So if you have your kid in the car seat, then take the stuffed animal, put it out front. I had one of the support staff that I work with would take one shoe off, put the shoe in the back seat, so she would never forget that her kids were there, because she would go out of the car without her shoe. You want to always dress infants and kids in loose, lightweight, light clothing, just like adults would. Encourage fluids frequently. You'll need to offer the fluids, but stay away from drinks with too much sugar and caffeine. Just the same measures for adults. And then there's a heat safety app, which I will show the QR code for. The heat safety app is provided by CDC. It is meant for the workers, but I use it all the time. I show it to others that are not using it for work. It shows you geographic, real-time heat index. It will project it over the day, so you can make plans for if you're going outside or outside in the future. And then it also has the signs and symptoms of each heat illness and the first aid and emergency response procedures. So you have it on your smartphone, and you can download it for the Android or the iPhone. So we'll look at that in a minute. So that's just a great way for them to have it at hand and not necessarily have to memorize everything. Next slide. For the older population, again, there's behavioral and physiologic issues. There can be issues with impaired sweating, less efficient sweating, less likely to sense and respond to changes in temperature. Also, the additional risk factors, more likely to have chronic illnesses, taking medications that may make their ability to adapt to heat, that may interfere with their ability to thermoregulate. And also there may be compounded with dementia. other circulatory issues, or isolation and mobility problems. So you have a long-term patient come into your office, and she's concerned about her 93-year-old mother who lives alone. She's independent, and but she minimizes the use of her air conditioning because she's concerned about the environment, and she doesn't want to put too much use on the Texas grid. So she keeps her temperature about 85. She does have hypertension, and she's on a diuretic. She does walk most days after lunch, but she's complaining to your patient about recent dizziness and fatigue. But she thinks it's her blood pressure medication, and she's asking your advice. What should she do? So, what counseling measures can you think of, or what strategy should you provide caregivers for elderly patients? Counseling those persons who are isolated, potentially immobile, may have cognitive issues. You want to check on these persons twice a day, ideally in person, but at least by phone, depending on their level of independence. Make sure they have easy access to fluids. And do they have access to air conditioning? Even though they may, there's many persons who don't utilize it because of the cost associated. Can you add fans to help? And just remember that fans after 99 degrees, if they don't have air conditioning, can actually increase their heat load. Do they know how to keep themselves cool? Check on signs of heat stress if they're not able to understand their own signs of heat stress, if there's cognitive issues. And check on their medications with a clinician. Is that an additional risk factor? Ways that they can cool are by keeping their shades down, and if they don't have air conditioning, maybe open their windows at night if that's appropriate. Going to areas like shopping malls, movies, libraries, senior centers, to have time periods in the middle of the day to cool off, but also just getting in the tub or shower. I did rural healthcare in family medicine before I went into occupational medicine, and I had one patient that filled her tub up with water, and she would just get in it periodically to cool off because she I'm pretty sure she didn't have electricity, period, and that's how she made it through the Texas summers. So there's ways that you can help your patients adapt, and then also for that caregiver use, or even the elderly person, to use that heat safety app. So for the next, we'll look at just quickly on a worker. Mr. Smith is a 60-year-old construction worker, and he needs a return to work or return to activity release. He had a total knee replacement, total knee arthroplasty, and has been out for approximately 3 months. He'll return to work in construction in July, but since his TKA, he has gained weight. He's not as physically fit as he used to be, and his BMI is now 34. So his risk factors are now age, low physical fitness, obesity, and he's no longer acclimated. You feel that he's ready to return to work, but you're concerned about his acclimatization. So what can you do for him? One, understand Mr. Smith understanding his personal risk factors, so he knows that he's at increased risk, is important. Knowing how he can prevent, knowing his preventive measures, and also to give him permission, even though his employer might not offer rest water shade, that if he has symptoms that he absolutely needs to take rest water shade, should he have headache, fatigue, dizziness, etc. And if his symptoms don't abate, that he should seek medical attention. The climatization RX we already discussed. You know, he could be returned to work, but with that 2 hour per day increase over 5 days or 14 days, depending on their risk factors and their environment they're going into. Next slide, please. So this is focusing on the athletes or the athletic group. There's behavioral, physiologic, and there can be, and obviously environmental for some athletes. So in this scenario, you're watching your child's summer soccer game. There's been a heat wave. So fortunately, coaches are rotating players and they're encouraging water, taking rest breaks. But you notice there's a referee that has not been taking breaks. You have not seen them drinking. They're profusely sweating and they seem confused. They're walking oddly on the field and then collapse. What do? Well, as we discussed before, this should be addressed like this could be a cardiac arrest. But in light of the heat wave, the physical activity of the referee, a young age, putting that together, you want to do rapid recognition, rapid assessment, and rapid cooling while you're waiting for emergency response team, while you're waiting for having someone call 911. If there's, you may need to ask others to bring water to douse the person with water and do the fanning to cool them off as quickly as possible while you're waiting for emergency transport. Just general counseling for athletes and athletic teams, all, not just the team, but coaches, stakeholders, the audience, the referees, all should have training or be aware of the risk of heat exposure and the health effects. A climatization plan for athletes going into a hot season, such as football practice starting in August, which tends to have the highest heat-related illnesses and deaths among school-aged athletes. Taking regular rest breaks for water, rest, shade. Also having high heat protocols for rescheduling games or practice now that temperatures are increasing. Having equipment uniform considerations because of the added heat load on individuals. Sports physicals. Most schools require sports physicals, addressing risk factors such as elevated BMI, maybe insulin-dependent diabetics or others. And of course, the Heat Safety app to be introduced to the coach as well. So let's look at an example of where these general measures were put in place and in a cohort of outdoor workers. So back in 2008, 2009, I was working with a municipality and treating heat illness after heat illness, and then looked into it further, realized they did not have any heat illness prevention measures in place. So put in a heat illness prevention measures, much as very similar to what we have been talking about with the heat stress questionnaire, identifying those with increased risk factors and so forth. After putting after several years and seeing improvement, we retrospectively looked at the data and published it. I was adjunct faculty at the University of Pennsylvania for their Occupational and Environmental Medicine program. And so myself with Dr. Judith McKenzie and Dr. Schofer published this data. So this is a retrospective analysis of heat-related illnesses occurring in this cohort before and after implementation of a heat illness prevention program. This program included supervisor and worker education on heat-related illness and preventive measures, also acclimatization after absence and prior to the hot season, and medical screening and medical monitoring if workers were for workers at increased risk. This study revealed 3 salient findings. Workers with 2 or more individual personal risk factors for HRI were more likely to develop a heat illness. The median cost per work injury for heat illness injuries went down by 50% per illness. And this was thought to be due to training, so earlier identification of having the heat illness, so less severe, so the less costly illness. And then last, the total number of heat illness cases decreased after implementation of this program. Next slide. So, oh, I'm sorry, I was the next slide, please. So this is that was just the face page. And so so this is basically we did the heat stress screening questionnaire, and we divided myself and the occupational health clinic that I worked in, that within the nursing staff that we worked with, we separated these individuals, this cohort of outdoor workers, based on their screening questionnaire, to those workers with no reported risk factors, those with one risk factor for increased risk, and those with two or more. Next slide, please. And those, the participants of the heat stress questionnaire, those without a heat-related illness, we separated those to who had it and their percentages on unreported, one risk factor or two risk factor. And workers who did have a heat-related illness were more likely and statistically significant, and you can go ahead and do the next click there, that had two or more individual risk factor were more likely to have a heat-related illness. Thank you. Next slide, please. And finally, the total number of cases decreased after implementation of the program. And even as you can see, so we had higher incidence in 2009, 2010 per 1,000 population, and it decreased over the years to where 2016, 2017, there were no reported illnesses. And the temperatures at that time was the hottest decade on record. So there was no specifically cooler years. Actually, 2011 was a very hot year on record. Next slide. So in summary, the key takeaways: heat is a serious health hazard. The best prevention, or the best intervention, is prevention. And you can you have an impact by recognizing risk, monitoring, and educating your patients. Next slide. Oh, I think I thought that there maybe was the heat safety app. Maybe it's down a little bit lower, but I will pass it on to Becky. And there is a QR code for that heat safety app somewhere in this presentation, I promise, but it's on the CDC.
We just wanted to make these two handbooks available. They have been produced by Texas PSR, and we hope to distribute them more widely. If you have any feedback on them, that would be awesome. Is there one more slide?
I think there is. There's a couple more slides.
Okay. Oh, so can we go back to the slide with the big QR code, like the giant one? There we go. So nurses, anyone who needs CNE for this event, use this QR code. It'll start with a survey, and then you need to take the post-test to be able to get credit. Next slide. So this is a one-pager that you can use to talk to your patients about the risk of heat illness, or just produce and leave in your waiting area.
That has the heat safety app QR code. And I guess I must have been off on some of my slides. I think I'm just going and not realizing I'm off on the slide. So I apologize. And I appreciate the chat, but I'm only seeing just a smidgen of the chat. I don't know why it's not coming up on my screen.
I can start giving you questions if we're ready. We got one more slide, right?
Yes.
I think.
In the New England Journal of Medicine, the first resource reference on there is a wonderful article if you have a chance to read it. All the references are great. So it's a wonderful article. And thank you so much for your attention, and I appreciate everyone's participation in this very important, timely topic. But But if you have any questions that we're not able to address tonight, here is my email and how you can contact Becky with Texas PSR.
And we do have a couple questions in the chat. If anyone else has questions, I think you can either put them in the Q&A or the chat. But up till now, everybody's been using the chat. And we are probably going to keep going until about 8:15 if we have that many questions, and then answer other questions offline. So the first question I have here is from Peter Wald, asking about the difference between the wet bulb temperature and the heat index.
Oh, that's a very good question. And like I said, I was trying to, in our time allotted, trying to just do more of a high level overview, but the wet bulb globe temperature assesses radiant heat, the heat index, air temperature. So it takes four different factors. So it's more accurate assessment of heat versus just ambient temperatures and just ambient temperature or heat index. Heat index is, so you have to have a special instrument to get the wet bulb globe temperature. Some employers do utilize it. Actually, there is a calculation that you can utilize on the OSHA, on OSHA's webpage that will help you calculate that wet bulb globe temperature. But obviously, like if you have a drier heat with less humidity and the wind's blowing for that evaporative, you're going to be cooler than if you have no airflow, or if you're indoors with the heat and don't have that radiant heat. So all those are very important factors as far as somebody's total heat load. And so that's a more accurate assessment. So you'll often see where when there's the wet bulb globe temperature will seem lower than heat index as a limit. But anyway, those take in all those factors versus say the heat index or the ambient. But it's heat index is more on how it feels outdoor and is more easily accessible. So that's often what people use to guide whether, what the temperature is and how dangerous it is or when they should stop or activities for workers and athletes.
So Michael Martin had a question. He said he had heard that there are some skin areas, for example, the neck, palms of the hands or soles of the feet, that are much better than others in terms of rapid cooling. And if you only have limited ways like ice packs or cold water, if there are particular parts of the body you should target.
Well, usually you do hear that, put ice packs in the axilla and the groin area, those places that are more vascular. But if you have somebody that you are concerned with a heat stroke, if you have any access to water, just think that evaporative cooling. If you can, put the ice packs, in those higher vascular areas, definitely. But then put water over their entire body, wet them, and then do the fanning for the evaporative cooling. That is, they have talked about putting their arms in water or their feet as well. But just, any way possible. If that's all you have, then that's what you use. But thank you. That's important to note. Just use what you have while you're calling emergency transport.
So one question was about whether or not folks could get copies of the slides. We will be able to circulate all the slides that have QR codes on them so that you can get access to all those materials. And I'm hoping I will be able to get all those materials on the Texas PSR website also so that they're accessible multiple ways. But we should be emailing you after this with all the slides that include materials. And then the last question was other recommendations for large-scale construction workers wearing half-mask respirators in the heat, hot sun, and higher humidity areas. especially working with cement or silica, something that they might breathe in.
I did say that currently there's not an OSHA a federal standard for the majority of states. There are some states that do have a heat standard, such as California, which right now is what we hope that OSHA will pattern the standard that they're currently working on. So we hope that there soon will be a heat standard to protect workers. There is a national emphasis program, and there is a significant amount of a national emphasis program that OSHA has that is encouraging employers to follow the recommendations that are on the OSHA site. Much of what we said here today is exactly what OSHA would recommend. There are specifics as far as engineering controls, administrative controls that we didn't go into today, but I would encourage any person that's in occupational medicine that is viewing this webinar to check out these pages specific to heat and look at those administrative and engineering controls to make those recommendations for employers. Because that is the expectation of OSHA, even though it's not required, it's highly recommended. Those are good questions.
So we don't have any more questions, but we have one comment, which is that Washington State has a standard for protecting outdoor workers from heat illness.
Yes, Washington State, Minnesota for indoor workers, and there are others following. And then, as you know, in Texas, we have soon to have changes in some of the municipalities as far as breaks that are currently allotted for workers. And thank you all so much. Thank you. And again, if you have specific questions, please don't hesitate to email myself or definitely, Becky for Texas PSR. So we can help spread the word to protect individuals and patients and those high risk populations from the health effects of heat. It's going to continue getting hotter this summer.
So we had one more comment from Rose Jones that Texas has the highest mortality rate for outdoor workers, which isn't super surprising, but is sad.
Yes, there are 3 states, California, Texas, and I believe Arizona. And thank you for others who are participating outside of Texas, because obviously this it is heat is affecting increased ambient temperatures are affecting us all, and it's all relative. I mean, Texans are used to pretty high heat, but it's what you're acclimated to. And so, and it's that change in temperature and whether you're having a heat wave. So all this information applies for even your state when there's a big jump in a temperature. But yes, Texas does have very high numbers of fatalities, occupational and others.
So it doesn't look like we have any more questions. I'll make one last call for questions. And we just have a lot of people saying thank you.
Oh, thank you so much. Thank you. I appreciate you spending time with us tonight.
So I guess if that's it, we will wrap up. Thanks very much.
I think I saw that there was a question regarding CME. There is CME associated with, yes, and you'll get an email regarding.
Yeah, I posted that to the chat to everybody, but yes, there is CME, and you'll get a certificate via email regarding CME credit. So I think that's probably it. Thanks,
Take
everybody.
care.
We hope
Have
to
a
do
great
this
evening.
again.
Stay cool.